Hello everyone. Isn't this fantastic? Thank you QCMB. This is just such a wonderful opportunity for everyone to come together and talk about something that I certainly love talking about and could talk about forever. My name's Sue Kildea. I'm the Professor of Midwifery at, it's a joint appointment between the Mater Health Service and the Australian Catholic University. I'm a midwife, I'm a nurse, I'm a bit of a rusty nurse, and I've been working in rural and remote areas for just about all of my career, a lot of it across the top end of Australia, but in various other places as well. It's kind of ironic that I'm now in the largest maternity service in Australia, I think, but they've been very generous with allowing me to continue my rural and remote interests, which is fantastic. So I'm going to talk a little bit today. I think we can definitely do it differently. I'm going to just build on what both John and Sue have already said, and certainly what the Minister has said as well. And I was given a few words: the why and the how, the costs and the evidence. So I'm just going to touch on some of those as I go through. Before I start, I'd like to acknowledge the land on which we're standing on today and the elders, both past and present. And certainly this map brings it back to us, doesn't it, of the incredible diversity and the strength of knowledge that is actually out in the bush in many areas. I'm taking us back to 2009, the Maternity Services Review, and some of the key points that came out in that were the point that it's vital that approaches that we make to change now are evidence-based and that they take full account of consumer preferences. And the priority areas back then in 2009 were rural and remote areas and services for Aboriginal and Torres Strait Islander people, which of course is important in rural and remote as well. Since then we've actually got the Maternity Services Plan, which is actually a fantastic document, and if we see the rollout of that over the next 5 years, particularly the bit that says birthing on country, which I was, a trial of birthing on country, I was very pleased to see. If we actually see that happen, the planets truly will have aligned and it'll be a marvellous thing. But one of the questions before I talk a bit more about that is the why, and I think what we don't see sometimes in our statistics is what happens when the maternity services do close down. And I went ferreting through some of the Queensland Health perinatal statistics to just have a look at what was happening with the women. The born before arrival numbers jumped up in front of me. So these babies that are being born before arrival, these aren't the home birth babies, these are the born before arrival babies. And what we've seen is that as over the last, John talked about the stats from since 1995, the closures, but this is just looking since the last 10 years, from 2000 to 2009, we've seen a 14% reduction in maternity services across Queensland. But we've also seen an increase in the numbers of babies born before arrival. And that is, you can see that it correlates not only with the years, but it actually correlates also with the fact that as the hospitals have decreased, the numbers of babies that are being born before arrival have increased. So, and we've seen this, haven't we? We've seen this in newspapers, baby born on side of the road. These are the women that are actually trying to get to drive straight past the local hospital that used to be open to them and go to the next one that is now open to them. So I think that's something that we just have to keep in the back of our minds as we look at reopening maternity services, that hopefully we'll see this curve go back the other, or not a curve, the straight line go back the other way. The other thing that I think is important for us to remember is that when we're talking about rural and remote services, we really are talking about services that are, hopefully, if we are going to make a difference to Aboriginal and Torres Strait Islander women, we have to do things in rural and remote areas. Unlike non-Indigenous women, where 71% of birthing women live in the cities, for Indigenous women, you've got 26% living in outer regional areas and 29–30% living in remote areas. If we're going to do anything that's going to improve the maternal infant health stats for our Indigenous Australians, we have to target these two areas, and we have to do it differently to what we're doing at the moment. So the evidence, John's already talked quite a bit about the evidence, so I'll just touch on, unfortunately I didn't see his slide, so I wasn't sure if this was a study you put up, John, but I think we've got similar studies but not the same. What I'd like to say, I've got a couple of studies that actually show that without a doubt we can now, I think, safely talk about birthing services in small areas that don't have access to maternity, to caesarean section capability. This is a study that's just come out. It's the UK birthplace cohort study. It's a very large study in the UK, and what they did is they compared the safety of births for women with low risk, so they were comparing like with like in 4 settings. They looked at the home, the freestanding midwifery units, the alongside midwifery units, so the birth centres next to the tertiary units, and the obstetric units. They found that the smaller units were definitely safe, and the safety was actually good across the whole UK. But the small units were safer for the mother and safe for the baby, but they also had additional benefits. And the units that came out the best were the freestanding midwifery units. So this is a very, very large study with fantastic evidence that shows us that we can actually do this and have good outcomes even without C-section facilities. Some of the lessons from the UK, it's a really big study and they had a lot of sub-studies in amongst it, and some of the lessons have come from the actual case studies, and they've looked at some of the smaller units and said, okay, well, what went well in these units? And what they found was that the positive organisational culture, often through really strong leadership, was one of the key things that made a difference. The learning climate was something that made a difference. So when things go wrong, adverse events, we don't try and pull somebody out and stick them out to dry. I don't think that's the saying, is it? Anyway, that's not what we're doing. We're actually trying to learn from it, and we want to improve from it. And that's what they found in the services that were doing really well. A cultivation of positive and respectful relationships, so that collaboration. And they looked at resilience in particular and found that it really depends on the flexibility of the service and the strength of the structure that supports the service. So if we get those structures in place that can actually support these services, they can then, flexibly, they have to be adapted for each and every different unit, but the flexibility and the strength of those support structures are really important. And they also found that the hub and spoke model, where you've got the big tertiary unit, and then you might have quite a few smaller standalone units that go out from that, and staff can actually sometimes go between one and the others to upskill as they need. They can support each other, and they get good transfer and referral systems in place in that hub and spoke model. They found that that was probably the best model for them in this study. The other thing I wanted to talk about is what we're seeing is the changing way that midwives are working. So in the past we've had midwives, particularly in rural areas, we've thought we need nurse midwives, they need to be staffing 24/7, we need to make sure we've got them on every single shift. We don't need to do that anymore. We've now got enough evidence to show that when we change the way the midwives work, and the caseload model, which is the model that Sue was just talking about that we've got here, we can actually do things differently, and the studies now are actually showing that we can do things a lot better when we do use these models. The Cochrane reviewers looked at 12,000 women in 11 randomised control trials, and that has found without a doubt many better outcomes for mothers and babies when we look at caseload or team midwifery models. The 2 big studies that are just coming out in Australia, the Cosmos study in Melbourne, which was a study for low-risk women, and the Mango study, which we participated in at the Mater, which was for women with risk factors, has shown that these models where you've got the known midwife going throughout and then all the support structures around as needed, is not only do we get better outcomes, we get less caesarean sections, we get less postpartum hemorrhages, increased breastfeeding, all the things we want to see, but we've actually found in the Mango study that it's cheaper, which has really been fantastic, quite stunning results. So not only is it a good thing to do, but it's saving money. So the why, I think, is really important, and we've got the other the other community that I like to quote is the community, the Pavugnatuk community in northern Canada, which in 1985 said, this is enough, we want to bring birthing back to our remote communities. And they did. And at that stage, they were 8 hours plane flight from the nearest caesarean section facility. They've got a faster plane now that's on the ground. They're still 4 hours flight away. And I went and visited last year, and they often get fogged in and can't get the plane out. But they have now got stats from 1985 on one of the most amazing services, and they're now popping up around other areas. But what they've shown, without a doubt, is that in very remote communities, birth can be returned to communities. It can be safe. In actual fact, their perinatal outcomes are better. But there's been all these other side effects that nobody even thought about. And it's talking about bringing back birth to communities is more than just birth. It's bringing back life. And some of the things that they said is that they found that it builds community capacity, and we've seen this with the closure of rural units, haven't we? The unit closes, people leave town, you're not building capacity, it's draining away from you. We see that it restores skills and pride in the community, intergenerational support and learning. They feel that it promoted healthy behaviours. They saw reduced domestic violence, reduced sexual assault, which they've put down to the maternity unit. Supports self-determination, and it enables better integration of traditional knowledge and Western knowledge. And the other thing that's really important about rural and remote maternity services is this cascade of normal. We hear a lot about the cascade of fear, but what happens in rural and remote areas is the cascade of normal. We're talking about normal again. And I think it becomes, you start talking it up and it actually starts happening. You get this beautiful cascade of things going normally, not that terrible cascade of intervention that ends up with a Caesar and postpartum depression, but this is normal birth, a culture of confidence in normal birth. So the how. The how is really important. I think that's why we're seeing in some communities and across Australia, we're seeing people are actually getting out there and getting on with it, and we've got great examples of that here in Queensland and here, of course, in the town that we're in. But health systems don't naturally gravitate towards equity, and I believe unprecedented leadership is needed. And if you've got that leadership locally, that strong leadership from all of your professionals, the midwifery professionals, the obstetric professionals, the medical superintendent, the nursing professionals that are now going to actually have to think about maternity services being delivered differently, if you've got that, then you're more than halfway there, 90% at least. I don't think it is business as usual. As much as I'd like to say back to the future, I think the future is going to look different like it always does. I think we do have to think differently, and some of the certainly the different ways of midwives working is we can't go back to trying to make sure we've got midwives staffed on every shift. That's just not going to work, I don't think. But we've got the blueprint is out there on how we can do it. I do remember a colleague of mine who's a director of nursing in a rural unit said, oh my goodness, if I could outsource my maternity services and my midwifery so that I didn't have to worry about staffing every shift with midwives, I'd do it tomorrow. And I think that's what Liz is going to talk about next. But, you know, we can do it differently, and we've got the information here on how to do that. And just briefly, I know I've just about done my time. I wanted to tell you a little bit about, we did a redesign of the services in the Northern Territory, and we worked with 2 remote Aboriginal communities and Darwin and the Aboriginal Medical Service there. We mapped the patient journey, and I'm not going to explain this diagram below, but the red lines there were where we had discontinuity of care and where we were adding health system risk to the women as they journeyed through our services. We looked at reorganising care. We did a hub and spoke model. We did a caseload midwifery model with Aboriginal health workers mixed into the model. And outreach, we had midwives who were midwifery only positions, not nurse midwives, in the remote communities. And we have actually, we're at the 5 years the 5th year data collection on this, and we've seen the most amazing change. Not only does it seem to have made it's certainly improved clinical outcomes, but it seems to have changed the culture of Darwin Hospital so that it is now becoming a much more culturally responsive hospital, which is fantastic. It's certainly being done differently. There was a real fear that the cost of this was going to make it vulnerable to closure. It costs $1.5 million a year to run, and everyone thought, oh my God, when they see how expensive we are, we're going to be closed. We did the costing. We looked very, very carefully and did a very, very thorough costing, and we actually found that it's cost neutral. It hasn't cost more money. What has happened is that we've seen a lower acuity in what's happening. We've got women are not having the catastrophic outcomes that they have, the DRGs that are catastrophic. We saw a decrease in that, decrease in NICU presentations, the neonatal nursery, and also a decrease in the length of stay. So these models, when we get them right, they might look like they're costing money setting them up, but if we get them right and follow the recipe and keep them right, we're going to save money and we're going to get better outcomes and we're going to be able to boost the rural communities. Other evaluations have shown cost savings as well. I'm not going to talk about that. But I think this is what we want to see, more birthing services ahead. Thank you.
Thank you.